Hello everyone, Yuma Lundy. Hello and welcome to the second in our series of webinars featuring international and local experts. I'm Elizabeth Moore, Coordinator General of the Office for Mental Health and Wellbeing, and your co-host tonight, together with Professor Luis Salvador Curula. I'd like to formally acknowledge the traditional custodians of the land on which we are meeting separately and together. And in my case, that's the Ngunnawal people, and pay my respects to their elders past and present, and the elders of all cultures gathered here today. Luis, I wonder if you could move the slides on for me. Thank you, and the next one. So about the series. This is a series in collaboration with the ANU and the Office for Mental Health and Wellbeing. And all the webinars are recorded and they will be made available publicly. Your display name and any questions you may ask will be included in the recording. And access to the recordings will be via the ANU Centre for Mental Health Research website. I would also ask you to follow, if you are on Twitter, unlike some troglodytes, myself, follow the ANU on Twitter and the handle is there. Next slide, please, Lewis. So we're all very used now to webinars, but just to remind yourselves that Zoom housekeeping, your microphone will be muted. If you need to contact the organisers or the panellists, please use the chat function and send a private message. We're also using the chat function tonight to write questions and to enable all participants to see your question. Lewis will be asking the question on your behalf. If there are questions on the same topic or theme, then we may combine them and they may not necessarily be asked in the order received. So next slide, please, Lewis. This is our program for tonight. And I'll pass over to Luis to introduce Sonia, but we're very proud to have Sonia tonight to do her presentation on loneliness and mental health, followed by our discussant, our eminent discussant, Hugh Mackay. And at 6:30, we'll have a question and answer session facilitated by Luis. So now I'll pass over to Luis to introduce our first speaker.
Thank you very much, Elizabeth, and good day to everyone. It's a great pleasure to introduce you, Professor Sonia Johnson. She's Professor of Social and Community Psychiatry in the Division of Psychiatry at the University College London. And she has published research in a broad range of topics relevant to care for people with severe mental health problems, including crisis care, early intervention psychosis, women's mental health, and digital mental health. We have worked together in the area of health service research for 25 years now, and she developed the instrument for assessing and coding services that we are using now in Australia for mapping the mental health care system in our country. She's currently the director of the NIHR Mental Health Policy Research Unit for England, and she's also the lead of the United Kingdom Research and Innovation Network on Loneliness and Social Isolation in Mental Health. So Sonia, please, we are really happy to have you here.
Thank you very much for that kind welcome. I'm very pleased to be with you in Canberra, sort of from London, where it's quite early in the morning. I must apologise, we've got some rather noisy building works opposite our house, which obviously I can't mute as I'm speaking, so I hope that's not going to interfere. But I'm just going to share my screen now, and as this is a relatively long presentation, I'm going to try and pause after about 20 minutes or so and see if there are any questions at that point. So I'm going to give you quite a broad overview of what loneliness is, what we know about loneliness and mental health so far, and then I'm going to talk about two things that I'm involved in. One is a community navigator study, which is a study in which we've developed a loneliness intervention that's tailored to mental health settings. And the other is about a network that I've been involved in setting up recently to research this. And it's a bit inescapable, isn't it? So I've added a short footnote on loneliness and COVID-19. Okay, so just taking a step back and thinking about interventions in mental health which have a social focus. It's a bit of a strange situation really, because we've known for a long time that there's a strong two-direction association between mental illness and social adversity, that both social adversity is a powerful risk factor for mental illness and vice versa. And yet, if you look at guidelines like NICE and other guidelines around the world, they actually include relatively few social interventions, despite the fact that we've known for so long that the social is very relevant to mental health. And the evidence base for social interventions remains really pretty limited. The situation we're in is that after several decades of research on psychological and pharmacological interventions, it's not really clear from the long-term cohort studies that outcomes of, at least in severe mental illness, have really improved. So it seems an obvious opportunity. The social provides a fresh opportunity to try and shift that needle and to try and find some new targets for interventions to improve mental health outcomes. However, one of the reasons why perhaps we haven't targeted the social all that much up to now is that it's a pretty complex task, and whereas we might take the consulting room as our focus for delivering pharmacological or psychological interventions, we need to think much more broadly when we think about trying to change people's social circumstances, trying to target social risk factors. So that's a bit of context about social interventions. And loneliness really is one of the more promising targets as a potential social factor that might be a way into influencing mental health outcomes. I started with some of my research group getting some research going in this area, I think in about 2012. It's striking that when I first started, people thought it was a bit strange actually, and I got people asking me, is that something you can really research? And surely that's a kind of private matter, whether people are lonely. And it's in the intervening years, in the last 7 or 8 years, it's gone from that to being a very prominent public concern that there is a lot of public discussion about. So there's been quite a striking change. And I guess there are two sets of opportunities related to loneliness. One is to try and prevent mental health problems by reducing loneliness in the population or in at-risk groups within the population. And the other is to try and improve outcomes in people who already have mental health problems by reducing loneliness. And what I'm going to say is relevant to both of those, but a bit more to the second one. So first of all, it's always helpful to start with a definition, isn't it? What is loneliness? It's by definition a subjective state and an unpleasant state in which people feel that their connections to other people are insufficient in their quantity and or quality. It's not solitude, which could be a good thing. There could be positive aspects to being alone, and solitude is the word that's more often described in that way. It's also distinct from, but somewhat related to, social network, social isolation, social capital. And if you want a sort of more thorough conceptual look at this, I'd recommend the paper that's shown on the screen that was written by Jingyi Wang, who wrote a great PhD on loneliness with me. And when you look at how far these concepts are related, loneliness is associated with the objective size of somebody's social network, but only quite moderately. So the two are related, but not all that closely related. And loneliness is the part that's subjective rather than objective. So isn't it just part of normal life? Yes, it is. So there aren't many people who don't feel lonely sometimes. I'm intrigued by my husband, actually, who Lewis knows well as well, who claims to have never really felt lonely. So he's a bit of a case study for me, but perhaps he's just saying he has rather more company in his life than he necessarily wants. But generally, if you ask people, they do have experiences of feeling lonely. And the theories around this, if you look at the writing of John Cacioppo, he's a very prominent American theorist of loneliness and researcher on loneliness. And he suggests that, in a way, loneliness is a bit like a social hunger, that it perhaps has an evolutionary value in getting us to reconnect with other people, and that there's a sort of natural cycle where people feel lonely and then seek out connection with other people. But the situation that we should perhaps be more concerned about in loneliness, in mental health, is where that fails, where either people don't have that impulse to reconnect, or where they're not successful in doing so, and they therefore become persistently lonely. And Pamela Qualter, who's another great researcher in this area, suggests that for many people there are phases in their life where they're at risk of loneliness, but that there's a smaller group who have a sort of trajectory of being persistently lonely through their lives, and that they are perhaps a group who are a proper concern for researchers, including in mental health. And there's a bit of a mismatch actually with that and a lot of mental health research so far, which tends to measure loneliness at one point in time, which may not actually be so very relevant. Okay, so is it an epidemic? Well, there's a lot written in those terms. If you want a sort of long view of loneliness in a broad social context, I'd really recommend that you read this excellent recent book by the historian Faye Bound-Alberti, published at the end of 2019. She makes an argument, I don't know if she's right or not, but it's an interesting argument, that loneliness kind of emerged as a concept around 1800, and that it's probably not exactly an epidemic, that there probably hasn't, at least in most countries, been a recent big increase, although possibly more so in younger people, but that it might be something that's better viewed as endemic, at least in the developed world, in the last century or so, which is a period during which people are vastly more likely to live on their own than, say, in 1800, when very few people lived alone. One thing that I think to bear in mind through all this is that we're focusing on this quite individual level concept of what's gone wrong socially. But actually there is a danger inherent in that. It's natural for us to do so with a sort of clinical view of what we can do to help. But I think we need nonetheless to consider that that can be a smokescreen for more deeply rooted societal problems that actually contribute to loneliness. And that's one argument that people often make, for instance, that's a critique of recent British policy initiatives on loneliness, that they're individualizing societal problems, whereas actually a period of austerity and underinvestment in the public realm has resulted in deeper structural problems. So as a clinician, I'm focused quite a bit on this individual level, but keen for you to remember the underlying structural and societal issues. Okay, so as my colleague said when I first started doing research on this, isn't this rather a complex personal experience? Is it fair to reduce it to a checklist and attempt to measure it? Well, it certainly can be measured. There are long established measures. Most research tends to use the UCLA loneliness and the de Jong-Gierwelt scales. They're self-completion scales of several decades standing with various versions, long and short. Epidemiologists who obviously like simplicity not infrequently use single item, are you lonely questions, or questions with measures with just a few questions. So that these measures are validated, they are related to many significant indicators. They're presumably not meaningless, but they certainly have their critics. They're several decades old. Sometimes that shows in the language. As far as we're concerned, they're not in any way tailored to a mental health context. And something that's now often pointed out is that they're not this kind of scales that we might develop now with input from the lived experience, from people with relevant lived experience. And one argument that's very often made and for which there's a good research basis is that we should probably see loneliness as not a single construct, but a group of interrelated constructs. And the de Jong-Gierwelt scale goes some way in this direction in distinguishing social forms of loneliness that are more about the kind of feeling that you're just not having enough contacts with other people to be emotionally satisfied, with more emotional forms where people tend to feel lonely even when they're surrounded by other people. And this is just to give you a sense of what it's like. This is the UCLA loneliness scale, which you'll note doesn't actually use the word lonely, and that's often a dilemma, is whether to talk about loneliness, given that it's been regarded as quite a stigmatized concept. It does have significant stigma, but I think people maybe now are tending to say that actually it should be a discussion that's out in the open. I think there's perhaps a move in favor of talking more openly about it as a problem. So who's lonely? One person I suggest you read on this subject is Michelle Lim, who's a great researcher on loneliness at Swinburne University. I'm sure many of you will be familiar with her work, and another person who's got a huge body of very interesting work looking at patterns of loneliness and how it falls over the life course is Pamela Quilter, who's in Manchester. So do look up their work. Particularly Michelle has just in the past couple of weeks published a huge review on understanding loneliness in the 21st century, which brings together a lot of work in a very helpful way. But briefly, groups who tend to be lonely it peaks in older age, where things like bereavement, isolation are felt to particularly contribute. Younger people, there's a peak between 18 and 24 that's, again, less of the sort of social loneliness side kind and more an emotional loneliness that reflects rapidly shifting relationships and insecurities about identity during a period when people are establishing their social identities. As I've already said, it's strongly linked with important social risk factors like lower income. It clusters with many other forms of social difficulty. People who live alone are not surprisingly more likely to be lonely, as are those who are bereaved. Physical disability and sensory deficits come with much heightened risk of loneliness. Carers, new mothers, students, and also refugees and migrants are again more likely to be affected. There's a bit of discrepancy between studies about whether men or women are more affected by loneliness, but it seems the patterns may be different, but both are quite affected by it. And there's mounting evidence, although not all of it unequivocal, about its various effects on physical and psychological outcomes. So in physical health, interestingly, in physical health, this tradition of loneliness got going rather before it got going in mental health, with findings of things like poorer outcomes in stroke, cardiovascular and respiratory disease, increased risk of premature death, although not entirely clear whether loneliness or social isolation is more responsible. And not surprisingly, people use various health services more when they're lonely. And there are some potential mechanisms put forward for some of the physical effects of loneliness. So what do we currently know about loneliness? Well, the research got going actually rather later than in physical health, and it's still not that robust. But we know cross-sectionally that it's associated with most types of mental health problem, and particularly strong associations have been found with depression and with having a personality disorder diagnosis. We don't know that much about its effects on outcomes, but we do know for depression that it makes prognosis worse. We know that the relationship between depression and loneliness is probably a circular one, and that makes often causality harder to unpick. In trying to understand what might be specific to mental health contexts, we're seeing that stigma and self-stigma seem to be big issues that are associated with greater loneliness, experiences of social exclusion and self-stigmatizing views. And Michelle Lim has written quite a bit about the importance of social anxiety. But really at this point, we could do with a better understanding of how people experience loneliness when they have mental health problems and what they think might help. I guess the overall aspiration of this work would be to improve mental health outcomes by reducing loneliness, but maybe actually reducing loneliness is a justifiable goal in itself, given the unpleasantness of this experience. There's always a bit of debate about primary outcomes with research on loneliness in mental health and whether loneliness is a suitable primary outcome, or whether you have to be able to show a clear impact on mental health. So just to give you an example of some work looking at how loneliness is distributed, this is again Jing Yi, my very brilliant PhD student, who's now gone back to Shanghai to perhaps do some research on this there, who found that about 30% of a sample of people who'd just been discharged from a crisis service reported severe levels of loneliness. And there were few, particularly people with depression tended to report high levels of loneliness, but actually there weren't that many demographic associations. It was almost as if it trumped, having a mental illness kind of trumped the demographic risk factors. And the causality wasn't that clear from her study, but there were strong associations with most clinical and social outcome measures. She also did a systematic review of what we know at the moment about impact on mental health outcomes. And again, this came up with this finding of worsening depression outcomes. So we know that loneliness is important and has an important relationship to mental health, and that many people, particularly with long-term mental health problems, are lonely. We certainly need to know more about the details of their loneliness and how it, I think particularly how it plays out over time and how it's related to conditions other than depression. But probably it's prevalent enough to think that we should try and do something about it, given that we know it's in itself a distressing condition. So just flagging up the work of another one of my excellent PhD students, Farhana Mann, who wrote this paper describing a typology of loneliness interventions in a mental health context. So before I go over the types of intervention, I guess one broad point is that the evidence seems to be that it's not enough just to help people have more social contact. That seems to be a way of reducing social isolation, but not loneliness. There are a range of candidate approaches that targets of psychological and social underlying mechanisms to varying degrees, but what we don't really yet have are mental health specific approaches that maybe take in mental health specific challenges such as stigma and perhaps limited social skills in some conditions. It's likely that successful approaches should be ones that can be tailored to people's social and cultural context, to the interests and to their experiences of loneliness. And again, to flag up that I'm talking largely about individual level approaches, but we mustn't forget the powerful impact of societal factors on these individual experiences. And I'm just to also flag up that especially in the current context, we could do with knowing much more than we do about potential digital tools in addressing loneliness. So what types of approach are there? Well, perhaps curiously, most of the more sort of scientific research so far on loneliness is actually on kind of individual level approaches using psychological techniques to try and help people who have chronic loneliness. And one thing that's observed about people who are lonely is that they tend to make more negative attributions about other people and to have negative expectations of their success in relationships, and indeed to hold back from those relationships. And various psychological techniques have been developed to try and address those expectations. And there's a small body of RCT, of randomized controlled trial literature, most of them feasibility studies on interventions to change cognitions, some of them based on CBT, some more innovative ones and things like mindfulness and positive psychology, or using digital tools for psychological approaches. And at the moment, the evidence, there's preliminary evidence on some of these. One thing that I'd recommend looking at, again, if you're again from Australia, is the work of Alex and Catherine Haslam in Queensland, who have in a very interesting way applied social psychological theories to trying to help people with their groups for health approach, which is based on theories of social identity and helping people to build positive social identities and group memberships which have been shown to be associated with lower levels of loneliness. So other potential approaches, one is around trying to improve people's social skills, or indeed to try and educate them about how much we need relationships and about ways of trying to prioritize that. Perhaps it's something that people should be taught from relatively early on in their lives, that actually, just as you try and keep fit to stay healthy, you should also perhaps try and maintain your social relationships as much as you can. Not much RCT support in this area, not much has been done, but perhaps one can see value in this as part of a sort of combined approach for people with mental health problems. Another approach is to focus more actively on supporting people to build connections, and these approaches involve people who may be called community navigators or community connectors, who try and support people. Often it involves helping them to choose and engage with activities. Sometimes also helps them try and rebuild past relationships, maybe combined with what's called social prescribing, where you prescribe activities classically rather than medication, sometimes with a budget to support those activities. There's a lot of enthusiasm, certainly in the UK, for this approach at the moment. There's a UK national policy of rolling out a sort of community navigation plus social prescribing model, despite the fact that at the moment, certainly in a mental health context, there's not a great deal of robust evidence for it. And one thing to say about that is that it certainly has potential value, but the current models don't look as if they're really tailored to severe mental illness. And this may or may not be linked to more of a community focus on trying to support people who are lonely or potentially lonely. So asset-based community development approaches involve identifying what a community can offer, what's going on in a community, and trying to support that and link people in with their wider communities. And there have been some interesting town or city-wide initiatives. For instance, in Manchester, there's been a big camp in Manchester, UK, there's been a big campaign focused on trying to reduce loneliness in the population by developing community assets and linking to them. One thing I think we've seen in the recent pandemic is that even though communities may be actively helping each other and seeking to enrich what's on offer, it's not always easy for people with relatively severe mental health problems to engage with that, and they're not always the recipients of those sort of community endeavours. So what do we know about the effectiveness of all this? Another of my loneliness PhD students, Roman Ma, who's just recently published a systematic review, which essentially shows that at the moment we have sort of bits and pieces of evidence, on the whole, small feasibility studies and things, but still there's a lack of big trials, if one sees those as a useful method, that allow clear conclusions, perhaps partly reflecting the fact that a lot of the activity there is outside the sort of clinical sphere, where it seems natural to use that sort of methodology. I think also my and other people's experience is that there's still perhaps a reticence, I can say, after a few failed shots at large trials, there's a reticence among funders about matching the policy and public enthusiasm for thinking about loneliness with funding large trials in this area. So I want to to now say something about the study we have done, about our own feasibility study. And if any funders are listening, this is now your opportunity to fund this one at scale, as we've just submitted an application to do a large study based on this. So this was led by Bryn Lloyd-Evans, who's an associate professor at UCL with me, and what we were seeking to do was to focus on people with severe depression and anxiety who use mental health services, and to develop an intervention for them and carry out a feasibility study of that intervention. So the intervention was developed through a sort of co-produced approach. Over several months, we had 8 meetings of a co-production working group that involved people with relevant lived experience, clinicians, researchers, and that group consulted with various experts in the field, various providers in the voluntary sector of relevant approaches. We consulted the HASLAMs and looked at their groups for health approach. We looked at the relevant literature, and on the basis of this, an intervention manual and a theory of change model was developed. The components of this, so the intervention we came up with involved these people called community navigators. They were recruited not for mental health expertise, generally that's not what they had, but they had good local knowledge, enthusiasm, and they tended to come from sort of backgrounds with coaching, connecting people kind of experience. And one of the voluntary sector providers who helped us recruit advised us that there was a certain sort of twinkle in people's eye, that you could recognize that they were the kind of people who were good at getting other people to do things that they felt reticent about. So these community navigators worked for people for up to 10 sessions for up to 6 months, had £100 budget to spend. There also was a group element, although people weren't always very keen to come to that. And it was an add-on to standard care from a secondary mental health team. They received some training and support from that team and some supervision from the social workers in that team. And some of the components of the intervention involved supporting people in using a tool to map their social world, in making a connections plan, which I'll show you in a moment, in thinking about how to build their social identities. We gave the connectors the navigators a bit of training in a sort of solution focused approach to helping work with people on their challenges in trying to see through connections plans. And we told the navigators that easy though it might be to be drawn into them, they should really just focus on connections and activities and not on trying to help sort out people's many wider social problems, such as with benefits and housing. So this gives you an example of a connections plan and how it played out, and the ways in which the ways in which this person engaged with new activities. And for some people, connections plans were very much about making new connections. For others, in other cases, the navigators did support them with trying to revitalize old connections and old identities. And various positive reports of feeling more confident and more comfortable with others. And they were happy to work with online or phone forms of connection if that was what people wanted. So we did a feasibility trial of this in 4 London boroughs. The paper, by the way, was the one I showed you at the beginning. It's just come out. 30 experimental and 10 controls, because we wanted to maximize experience of the intervention. It was actually one of the easiest trials I've been involved in to recruit to. It proved to be a very popular intervention with both staff and students, and we retained people very well. we used the de Jong-Gierwelt scale, and that actually turned out to be problematic because it had a real ceiling effect, because people's levels of loneliness were so high in this population at the beginning. They wanted, the service users we included really wanted more. They felt that, and so did the navigators, they felt that it was hard for people to take small steps forwards, and that a longer intervention would have been beneficial. Wasn't powered to detect a significant effect, obviously with 10 controls, but this is very small, perhaps reflecting the small significance of it, that we couldn't come to any firm conclusions. But the scores on depression and on loneliness were in the right direction, which is reassuring if one's seeking to do a bigger trial. And hopefully the lucky funder is out there somewhere who's soon going to fund our large multi-centre trial based on this. And these are a few quotes about how people found, how people experienced the intervention. One thing was that the navigators were really very nice, inspiring people, and it's perhaps hard to quite disentangle that from the specific approach that was taken. So what's challenging about researching intervention and researching loneliness interventions? Well, I think one thing is that it's not so clear how well the classic RCT design really holds up. Funders, close your ears at this point, but social context is obviously enormously important to how well a model works. A model that works well in a relatively socially rich community might be much more difficult to implement somewhere in a community that had few social assets or material resources. It's likely that you really need to individualize intervention strategies to people's interests, to type of loneliness, to whether people are working digitally or in real life. There are all sorts of ways in which it's likely to be necessary to fit things to where people are and to what kind of loneliness they're experiencing. However, to more positively about these approaches, we found that mental health service users and survivors are very positive about this as a focus for research, that they tell us that this is an aspect of their lives where they do really feel is relevant to helping them. And there are many potentially interesting approaches and many potential cross-disciplinary collaborations, and they're given the strong associations between loneliness and many outcomes, particularly related to quality of life. Perhaps there is considerable untapped potential here for benefiting people in their lives. So wanted to point out something we're doing to try and help release this potential and foster collaborations. So I'm leading with Alexandra Pittman the UKRI network on loneliness and social isolation in mental health. This is one of a number of interdisciplinary networks funded by all the research councils together to try and get different disciplines working together and to try and come up with a step change in this area. It's absolutely fascinating working on this. We have people from disciplines that range from psychology to music, art, architecture, history, and we have done scoping work and looking at research priorities, looking at the current state of the evidence. We're doing a qualitative investigation of loneliness experiences. We have quite a number of events. So I think tomorrow afternoon in the UK, although I think the Australians among you will be asleep, unfortunately, but we've got a big event on community navigation type approaches. And we've been able to fund, we've got a resource to fund small projects, not ours, but other people's small projects that look as if they're seeding something significant in this field. Okay, so finally, I don't feel I can talk about loneliness without saying anything about the current pandemic. So what do we know? Well, we're starting to see population studies being published, such as from the Office of National Statistics, that show very broadly what's happening in terms of loneliness during the pandemic. Not surprisingly, there has been a rise in people experiencing loneliness, especially it seems in younger age groups. Seems that those people are a mixture of people who've always had quite a lot of experiences of loneliness and some people who have a particular impact from the lockdown, that the lonely are kind of fairly evenly divided between those groups. And not surprisingly, that loneliness is associated with poorer well-being. In the policy research units where I work, we've done a sort of very broad synthesis on what people have written about the COVID-19 impact on mental health care and mental health service users. And we found that people with mental health problems have attributed feeling lonely to lockdowns, but also to the closure of community services where they often found a lot of peer support, and actually to isolation in hospitals. So a lot of inpatients are currently very cut off by restrictions on visiting, on leave, by loss of sort of group activities in hospital. Also comes through that impacts on people with severe mental illness are quite complex and variable, that some people are actually used to being very isolated, and some people even describe feeling that they do have a resilience in this situation, or perhaps that the situation has changed things less than for other people. So I don't think we can make easy assumptions about, you know, what's happened to people. Probably varies a great deal. Obviously, this situation makes digital and telehealth means of trying to alleviate loneliness especially significant. And we are doing, in the network combined with the policy research unit, a qualitative study looking at service user experiences, on which we hope to be reporting in the next few weeks. Okay, I don't think you need my summary, but so thank you very much for listening. I thought that's the view from my window, just to kind of connect where I am here in London with you out wherever you are in Australia or elsewhere in the world. And that's my Twitter handle, and also the Twitter handle for our network, which I do recommend that you follow if you'd like to hear more about our work and about loneliness in general. And thank you very much for listening.
Oh, thank you very much, Sonia. It has been fascinating. I remember when you talked me about for the first time about this topic, and I thought, well, it seems interesting. It was 3 or 4 years ago, and now you have a construct, a typology, a psychotherapy of loneliness, types of specialists working on community navigation for loneliness, and all this whole set of multidisciplinarity approaches to the topic. It's absolutely amazing. And I am seeing just a lot of questions coming to our chat. And I will give now the virtual floor to Elizabeth, and we will keep on at the Q&A. Elizabeth?
Muted.
Finally got the mute button. It's now my pleasure. Thank you so much, Sonia. It's now my pleasure to introduce our Australian discussant. Hugh Mackay is a social psychologist, a researcher, and a best-selling author. In fact, it was his book, Australia Reimagined, that made me think that he would be a perfect discussant for this topic. He's a fellow of the Australian Psychological Society and the Royal Society of New South Wales. And in recognition of his pioneering work in social research, he's been awarded several honorary doctorates, and in 2015 was appointed an Officer of the Order of Australia. Hugh, the floor is yours.
trying to yes, there we are. I'm unmuted. Thank you very much, Elizabeth, and thank you, Sonia, for such a wonderfully comprehensive overview. And obviously, I don't want to take issue with any of it, quite the reverse. What I'd like to do is emphasize a few of the points that Sonia has made, and then just add some thoughts of my own relating particularly to Australia, but most particularly to the social rather than the individual dimension of this. Sonia, I think, has very helpfully reminded us that loneliness is a multidimensional construct. It's subjective, of course. One person's loneliness is not another person's. Social isolation doesn't guarantee loneliness, etc. That loneliness is strongly associated with mental illness as well as many physical ailments. And that, I think, is an emerging aspect of the literature on loneliness that we need to pay close attention to. We think of loneliness bracketed with anxiety and depression. We don't always think of it as also bracketed with heightened risk of cardiovascular disease, hypertension, effect on the immune system, sleep disturbances, and so on. Loneliness affects a very wide range of people, from the very old to young adults in particular, and Sonia has reminded us that 18 to 24 year age group around the Western world is one where loneliness seems to be a growing problem, and I want to comment a little bit on that in the Australian context in a moment. And that given all the negative outcomes associated with loneliness, focusing on the reduction of loneliness itself might be a justifiable goal for interventions. Sonia's also speculated that community level initiatives might have more impact than those that are directed at individual cases, and the navigator work that she has referred to points to some pretty encouraging possibilities along those lines. Now, I'm a mere social psychologist. I'm not an expert on mental health at all, but let me offer you just a few additional thoughts that might reinforce some of the things that Sonia has said, and might also help to broaden our focus to think a little more about those societal issues rather than individual issues that could be relevant. And the starting point for this might strike you as absurdly simplistic and so self-evident that it's hardly worth mentioning. But I think it's useful every now and then just to remind ourselves about the kind of species we belong to. We humans are herd animals, like most other animal species on planet Earth. We need families, groups, neighbourhoods, communities of all kinds to sustain us and nurture us and give us a sense of our own identity. The thing we call the sense of belonging is vital to our well-being, and for many people, vital to mental health. So like all herd animals, we suffer when we're cut off from the herd. Is that too obvious a point to make? In our criminal justice system, we've devised solitary confinement as the worst possible punishment, because for members of a social species, it is the worst possible punishment. We know what the consequences of social isolation can be, and loneliness is one of them. Sonia mentioned Michelle Lim's work, and Michelle has recently said that anxiety is actually the best predictor of loneliness, but of course that also reminds us, as Sonia has suggested, that this is a bi-directional thing. Loneliness is a great predictor of, anxiety is a great predictor of loneliness, but equally loneliness is a great predictor of anxiety. Now, it strikes me that one of the great ironies, perhaps one of the great paradoxes of contemporary Western societies, and Australia is no exception to this, is that we know that social cohesion, social inclusion are vital for the health of communities, the health of neighbourhoods, and for the mental health, in particular, of individuals. We know that. And yet, most of the changes that have been reshaping our society are having a disruptive effect on local neighbourhoods and communities and families, and a fragmenting effect on our society. In fact, I think it's fair to say we are becoming more socially fragmented than we have ever been. And examples of the factors involved in that are things like, and Sonia mentioned some of these already, but things like our shrinking households. In Australia, now every fourth household contains just one person. And that ratio of 1 in 4 is rapidly heading towards 1 in 3. The Bureau of Statistics predicts within the next 10 or 15 years, every third household will contain just one person. That doesn't mean they're all lonely. It doesn't mean they're all socially isolated. But it means that as a society, we are significantly heightening the risk of social isolation with a consequence of loneliness. Our rate of relationship breakdown, I think, is another fragmenting factor, with between 35 and 40% of contemporary marriages predicted to end in divorce, and the proportion of non-marriage cohabiting relationships breaking down is higher than that. Clearly that's disruptive, not just for the people who split, but for the children, if there are any, for the extended family, for the friendship circles, and for the communities that people are moving in and out of. Our notorious busyness, I think, has emerged as a major source of social fragmentation. Too busy to chat to the neighbours. Someone's having drinks on Friday, too busy, got too much on. Busyness is like a barrier to social cohesion for many of us. Our mobility contributes to social fragmentation. In Australia now, as in America, I'm not sure what the UK figure is, Sonia, but in Australia, we're moving house on average once every 6 years. That's a lot of people moving in and out of local neighbourhoods, having a disruptive and fragmenting effect. And of course, one that we haven't really mentioned at all so far is the information technology revolution, this hugely paradoxical revolution that we're in the thick of, that's promised to connect us like never before, and it has, but it's also made it easier than ever before to stay apart. I want to say a little bit more about the IT revolution, in particular in its impact on that 18 to 24 age group. But just put those, I haven't given you an exhaustive list, but things like shrinking households, relationship breakdown, busyness, mobility, our embrace of the IT revolution, etc. Put all that together and consider what the cumulative effect is likely to be. And I think clearly the cumulative effect is likely to be to fragment us more, to disrupt our lives and in particular our neighbourhoods. And so I have come to think of some of these social changes, which we are all doing. I mean, this is not something that's being done to us. These are trends that we ourselves are propelling by the way we're choosing to live. So in a way, we could think of these as being a bit like self-inflicted wounds on our society. And the result of those wounds, the result of the cumulative impact of all those fragmenting factors, is that we do have a crisis of loneliness. Sonia has reminded us of the controversy about whether we should call it an epidemic or not. In Australia, we have been talking about an epidemic of loneliness, certainly Michelle Lim does. And that was way before the pandemic hit. In 2018, under the guidance of Michelle Lim, Swinburne University and the Australian Psychological Society published some research which showed that, and I found this one of the most dramatic pieces of social research, or statistics from social research of the last 25 years. But that research reported that 25% of all Australians report feeling lonely for most of every week. And the highest levels were in the 18 to 24 age group, and particularly among people who were the heaviest users of social media. Now, isn't that ironic? The expression connected but lonely now makes a lot of sense. Social cohesion and our sense of belonging, it turns out, who would have guessed, requires face-to-face encounters, not just the words that could equally go on a screen, but the word music, the tone of voice, the rate of speech, the cadences, plus, of course, all the facial expressions, the postures, the gestures, the all-important eye contact and the possibility of touch that create the richness and complexity of face-to-face communication, all of which we lose when we go online. So it seems to me not at all surprising that the sense of belonging, the sense of social connectedness, and the risk of loneliness would be greatly enhanced by the heaviest users of information technology. Now, putting all the things together that Sonia has presented to us, and perhaps some that I've just added in, it's perhaps not surprising that so many mental health professionals are now saying that loneliness is actually a greater threat to public health than obesity is. And a recent past president of the Australian Psychological Society has said of Australia that our greatest challenge is maintaining social cohesion. Sonia's references to the Navigator programs emphasise to me the huge role of the local neighbourhood in addressing the problem of social cohesion and social inclusion, social exclusion, social isolation and loneliness. Some wonderful initiatives are taking place in all sorts of local neighbourhoods and communities. Large-scale things like the Compassionate Cities project that's happening around the world, plus things in Australia like Neighbour Day, the Groups for Health Haslam project that Sonia referred to, various local governments running Meet the Street programs and so on. And certainly during COVID-19, we've been more alert in our local neighbourhoods to those who are at risk of social isolation. And just to conclude, that to me introduces what I think is a crucial moral dimension to our discussion of loneliness and alerts us to the bystander problem. It's very easy to look at all these social trends and their consequences, including loneliness, and to say, isn't that interesting? But the social trends are ones, as I've said, that we've driven. And it seems to me that loneliness is our problem. The responsibility as citizens also to be neighbours is our problem. It's not just a challenge for the mental health professionals. Thanks, Elizabeth.
Thank you, Hugh. That's really a call to arms, I think, for all of us. You brought it back to the societal level. Sonia has obviously not been a bystander in terms of interventions that she's been wanting to offer, and I think thank you for the Australian perspective on that. I'm going to pass over now to Luis to do the Q&A for both our panelists.
Thank you very much, Elizabeth. We have chosen to use the chat and not the Q&A option, because in the experience of our previous webinars with John Mendoza on COVID, we saw there was a way of dialogue that enhanced the contribution made by all the panelists and participants and attendees to this meeting. And this is happening now. We have a burning chat with a lot of things. I would like to start by asking Sonia if you would like to make any comment to Hugh's comments, if you want to reply.
Okay, sorry, I'd been muted by the host and wasn't able to unmute myself. Modern hazard. But yeah, I suppose I'm quite interested, although not really knowledgeable about these issues of social media and IT means of connecting. And I guess we've been a bit watching the emerging literature on social media and screen time and young people's mental health. And I suppose my interpretation has been that there isn't necessarily such a big overall relationship between screen use and mental health. And I do think that there's a message that seems to be coming through and that we're thinking about in terms of interventions is that maybe we do need to have a more nuanced approach to the idea of screen time than, and you know, the kind of endless hours of solitary Grand Theft Auto play might be rather different from the Zoom call to connect with old classmates who don't live in the same place anymore. So, and certainly digital is a potential, particularly in these times, is a potential tool for connection and for, you know, reinforcing connections that may also extend into the face-to-face world. So I do suspect we need to understand a bit more about what sort of technology can be helpful and what not so much, really, to come to grips with this.
Yes, could I just say a word about that, Lewis, if I may? Thank you, Sonia. I agree with you absolutely. I think the whole thing of screen time has been a bit oversimplified. We've thought about, and I mean, these are important questions. We have thought about the impact of screen time on brain development in children and so on. That's all important stuff to look at. But I think we have perhaps not been attentive enough to the fact that the time we spend on the screen is time we're not spending face-to-face. And to say that it's comparable connection, I think it's emerging that that's simply not the case. The COVID experience, I think, reinforces this, that many younger people in particular, but even people up the age scale, who've now had to rely on things like Zoom and emails and Twitter and Facebook and all of that, have reported higher levels of loneliness, even though they are wall-to-wall connected. Many people saying they're actually more connected with their families than ever before. They're talking every couple of days, whereas they previously only saw each other once a month or something, yet experiencing feelings of loneliness. And I think that there is a little bit of a warning bell there that's worth a lot more investigation.
Thank you, Hugh. In relation to that, there is a question by Brendan Lu G on the use, on whether there were digital tools used in this community navigation study that you mentioned.
No, not in any systematic way. I mean, if people, there were a few participants who were very stuck indoors indeed, and where the plans ended up being around getting them to connect with other people, perhaps by phone or online as a kind of first step, because doing that seemed to be the most feasible first step rather than trying to achieve face-to-face connection. But that's as far as it went. We didn't have a digital tool for the study.
I have group questions. For instance, there are several questions on loneliness and severe mental illness. Yeah. Scott Henderson just mentioned issues related to long-standing psychosis, where they are mostly isolated but not loneliness, because what happens is that they have a limited capacity for information processing. So their capacity of social interaction is lower. Then I'm just giving you this set of things. Second one is John Mendoza asking about the relationship between severe mental illness and stigma. And then the third one is Alan Rosen asking whether the trials you are suggesting, if you are aware of anyone that's focusing on complex mental illnesses.
Hello to all those people, by the way, and thank you for coming. So I think we need to, I mean, I think the studies on loneliness and psychosis are somewhat variable in their conclusions, aren't they? I mean, clearly people with psychosis report loneliness less than people with depression, but still they have relatively high rates in some of the studies. I suppose it seems important when people in that situation say they're not lonely and yet seem very isolated to actually understand more about what they mean, really, and about whether that does really mean that they're all right and they have all the connections that they might want, or whether they're just not expressing it in the way we expect. And certainly we're trying to do some work of a more qualitative nature to understand the experiences of people with various significant mental health problems, of loneliness and social connection, and that seems important. In terms of trials, again, to any funders out there, I and my colleagues have been trying for ages to do a trial in an early intervention service context with young people with psychosis, because helping them to build connections and not be lonely seems really important, but we've yet to find the funder who bites. And I'm not aware, there's some work by Domenico Giacco and Stefan Priebe that is on some sort of befriending approaches that I think would have loneliness as one of the outcomes. But and Michelle Lim has certainly done feasibility studies related to early psychosis. But as I say, I'm not aware of a sort of big trial in this area. If anyone else is, I'd be very interested to hear.
Right, thank you, Sonia. There are two questions related to post-traumatic stress disorder and childhood trauma, and in their relationship to loneliness.
So I believe they have one, and that's been that loneliness is sometimes seen as part of the model for some of the adverse effects of childhood adversity and bullying, which is related to loneliness, but I'm really not the expert to ask for a detailed account of what the thinking currently is on that.
And there are a set of questions on healthcare and mental health services and the role in loneliness. For instance, Alan Rosen again is asking about the role of more traditional interventions like assertive community therapy, treatment, or residential respite centers and crisis intervention services. What is their role in improving the situation of loneliness, or what is the relationship?
Well, I mean, I think obviously it's been usual to consider people's social relationships, particularly in something like assertive community treatment teams. I suppose it's striking going and talking to people in those teams, and for instance in the teams for people with severe depression and anxiety, where we carried out this study, that at least in the UK they don't seem to feel that this work is stuff that they're already doing. They don't seem to feel generally that they're taking a very sort of a particularly focused approach to helping people build meaningful connections, even though that may be something they're aware of. Certainly in the Community Navigator study, the clinicians, although they've been working quite intensively with some of these people, they still saw this Community Navigator approach as something that was really adding something extra, and that they were pleased, and also that was taking a different and non-clinical approach that they seemed pleased to see and felt was very potentially valuable. I'm not in all those types of teams. I'm not really aware of focused research that's gone on. I mean, this is a kind of area of research that's, although it's kind of risen quickly to prominence, it's only really just got going at any scale. You know, I think there's much to do, really.
Sonia, Erin Walsh asked about what she calls modern innovations in social connectedness. She mentions a program I was not aware of. It's called Mukbang. It seems that originally an innovation to allow Korean individuals who culturally would eat together but live alone to feel more connected. Do you know if there are these social movements or new initiatives?
Well, I think that's one thing, the potential value of our network and other similar initiatives, that I think the lack of research doesn't reflect a lack of relevant activity. And certainly there are many in the UK, there are many voluntary sector initiatives, including some fascinating ones that involve sometimes whole towns trying to take a different approach to people connecting. But often we don't have research evidence as to what the outcomes are. And in particular, I think we don't really know what works for people with longer term mental health problems. But that's certainly something we're trying to do in our network, is bring together innovators, sort of including social innovators and people in spheres like the arts who are sometimes doing very innovative work aimed at connecting people, and researchers, so that we can try and find out more about what works and what could do with being scaled up, really.
Can you tell us something about an initiative in the UK, the Safe Haven cafes, how they are working? You know anything about that?
I don't, I'm afraid. Sorry.
Yeah. And then there are quite a lot of questions related to social determinants, culture, that probably are questions for Hugh and for you, Sonia. One of them is the role of economics and the level of income, whether there are relationships between high income sectors of society and low income, and whether there are differences between high income and low income countries in relation to loneliness.
Hugh, do you want to?
Sonia reminded us that loneliness is more highly correlated with people of lower income living in poorer neighbourhoods. The Australian experience, I haven't got definitive research on this at all. My impression is that in the Australian experience, you generally speaking, you're better off in the middle in every sense. Medium density housing facilitates neighbourhood activity, reduces the risk of social isolation. Strung out low density suburbs, which used to be good for the way we used to live, are no longer so good for the way we now live. They're often extremely lonely places for people who are there all day. Similarly, high-rise is a kind of an anti-social phenomenon as well. But I think the question is a very interesting one, because I think it's not just low income that tends to work against social cohesion at the local level, but so does high income. In the most affluent pockets of our major metropolitan areas, where there are electronic gates and high fences and hedges and so on, anecdotally, you would say these, like people who are, for reasons associated with poverty, on the margins, there's a lot of social marginalisation that happens in terms of the neighbourhood in affluent areas as well.
And just, I'm aware in the UK that this is something that Michael Marmot's group have looked at a bit, and they do find that if you divide society into quartiles by income, each quartile, as the quartiles get poorer, they get lonelier. So he finds quite a clear relationship between loneliness and income. In terms of cross-cultural stuff, I don't think there's really that much good research looking sort of worldwide and looking at lower income countries. Within Europe, I believe Eastern Europe, and actually in some recent studies, Southern Europe, those countries report higher levels of loneliness than Western and Northern Europe, which is kind of counter stereotype, isn't it? I don't know if it's partly about people's expectations, but that's a sort of intriguing finding. But I don't think there's a sort of really solid body of cross-cultural research in this area.
It may be, Sonia, is because the Southern Europeans, we have lunch and dinner so late. There are some other questions related to these aspects, like on whether or not there are gender patterns where you can differentiate by gender.
So there's Pamela Qualter, who's this great researcher in Manchester, she's published a meta-analysis on this, and it basically says, no, not clearly, that people have found that there have been findings in both directions. There have been a variety of hypotheses, but gender doesn't seem to be a clear driver, according to this big meta-analysis she's published, of the extent to which people are lonely. Other aspects of their social situation seem to be more important.
All right. Sonia, I am aware of that you asked us to have 5 minutes to prepare for your next Zoom meeting.
Yes.
And, but I would not like to finish this discussion without asking you about one specific area you mentioned in your multidisciplinary work, that was art. Something with artists? Some artists working on this concept of loneliness, or?
Yeah, there are quite a few artists working on social connection and on ways of having shared projects or shared activities that sometimes in deprived neighbourhoods that foster connections between people. So at St Martin's School of Art in London, we've discovered there are people who are working on this area. The architects who are interested in loneliness as well. That I'm kind of only just starting to understand a bit more what's out there in terms of relevant work. It's fascinating if we can somehow find ways of knitting some of this together and bringing it into the mental health sphere. It has a lot of potential value.
Thank you, Sonia. Hugh, would you like to say a final comment on this?
Sorry.
Yeah.
I just thank you for listening, and it's an area that I think there's so much to interest and so much to do. I encourage everyone to get involved, really.
Thank you. Thank you.
Yeah, thanks, Lewis. I just want to echo something Sonia said. There's a lot more going on than the research would suggest. The activity is ahead of the study of it. And just that final comment about arts dimension to all this. I mean, I think one of the signs, very promising, hopeful signs of a revival of neighbourhood life around Australia is the absolute burgeoning of community choirs, community gardens, ukulele groups, all kinds of things that are bringing people together in ways that are reminiscent of how neighbourhoods used to be. And I think that's a very promising sign.
Thank you very much, you both, and all the attendees, and I let Elizabeth close this webinar.
Once again, thank you. Thank you both very much. It's been a fascinating discussion, and I'm sure it will continue. Thank you to everybody who attended. We will put up the presentation on the website, and we do have a slide with keep in touch, which may or may not come up, but please feel free to get in touch with either myself or Luis. Our next webinar will be with David McDade around mental health promotion at a time to be advised. So thank you all for attending, and thank you to our discussant and our presenter. It was a very interesting conversation. Thank you again. Good night.
Good night.
Bye.
Thank you.